Assalamu alaikum and a very warm welcome to all of you on behalf of ICON and PEDS Hematology Oncology Department in our scientific session. We will be here with you for next 2 hours and we have some very interesting topics and talks lined up for you. We will be happy to take question and answers at the end of the session and you can drop your questions in the question box. Just a reminder that you have to fill the feedback form at the end of the session to get the CMERs. Our session for today will be chaired by Dr. Rafi Raza. Dr. Rafi is a senior consultant and head of the Department Pediatric Hematology Oncology Unit at Indus Hospital. His specialty and area of interest are bone and soft tissue sarcomas and histiocytic disorders. Dr. Raza is particularly passionate about research and development focused on the progress of childhood cancer in Pakistan. He manages an NMCM outreach program involving 10 small scale pediatric oncology units across Pakistan, aimed at training and educational activities for pediatric oncology multidisciplinary teams with limited healthcare facilities. He is well published researcher with multiple accolades and awards to his name. He is also currently a Global Child Health Fellow with St. Jude's. Our co-chair for the session is Dr. Mohammad Fariduddin. He is a consultant and chair Department of Pediatrics at Indus Hospital. His specialty and interests are in pediatric pulmonology and rare metabolic disorders. He has been actively involved in conducting seminars and workshops on pediatric metabolic disorders and has several research publications to his credit. I welcome you both. We will be starting our first talk of the session by Dr. Asim Noor Rana. Dr. Asim Rana graduated from Ahmadu Bello University, Nigeria, followed by a fellowship in pediatrics from Pakistan. In 1998, he was awarded the prestigious Bill Marshall Fellowship in Pediatric Infectious Diseases from the Institute of Child Health, London. During his pediatric training in Pakistan, he developed a keen interest in the care of children with cancers, a neglected specialty at that time, and has dedicated his life to it since then. He trained under world-renowned pediatric oncologists in University College London Hospital, Bristol Royal Children's Hospital, and Christie Hospital, Manchester, gaining valuable experience over the next 9 years. In 2012, Dr. Asim moved to Dubai as a pediatric oncologist to support a growing pediatric oncology unit, currently the largest tertiary care pediatric oncology center for the population of Dubai and Northern Emirates. Dr. Asim has over 15 publications or papers in journals with journals international pediatric oncology conferences. We welcome you, Dr. Asim, on board. Dr. Asim will be giving his talk on anemia in children and approach to diagnosis. He will be presenting a simplified approach to diagnosis of anemia, which will help us all as pediatricians and will be a very informative session. So over to you, Dr. Asim. Dr. Asim, आपका mic mute.
Yeah, I guess it's working now.
Yes, it's working now. We can hear you.
Can you hear
We
me?
welcome you, Dr. Asim. Yes.
Okay. Assalamu alaikum warahmatullahi wabarakatuh. Good morning, afternoon, and evening, depending on wherever you are in the world. I'll be, as Dr. Kunatul Ain said, and thank you for her beautiful introduction. We'll discuss anemia in children, an approach to diagnosis. It's a very short time. I guess it's 15 minutes, even though I was under the impression it's 20 minutes, but we'll try to summarize things to look at how you should approach a child who comes with anemia to a ward, to a clinic, to anywhere in the pediatric services, wherever one is working. So without further ado, first of all, we have to get to the definition of anemia. Obviously, everyone will think anemia at different levels. For adults, it's sort of fixed. But in children, as we all know...
Sir, Dr. Asim, आपको screen share करनी होगी.
Passage of time and with the increasing age from birth, the hemoglobin is normally varied.
Dr. Asim, we can't see your
So by
screen.
definition, it said anything below 2.5 percentile for age, race, and sex is defined as anemia. So, for example, at birth, your average hemoglobin is 16.5 grams per deciliter. So the the standard deviations or 2.5 percentile will be
Dr. Asim,
30
sorry to
grams.
interrupt
Anything
you, but
lower
we
than
can't
that
see your
will be
screen.
classified as anemia in a neonate. Uh, but that, remember, is not the same as someone who is 7, 8 years old, because 13.5 is a normal hemoglobin for them. So we always have to be a bit mindful of what the normal range is for that specific age group is, to actually say, is it anemia or not? Just to have, so this chart sort of summarizes all of that from birth to adulthood. And this gives us a visual sort of scenario. So you can see at birth, there's a high hemoglobin. We all know why we have high hemoglobin at birth, because of the low oxygen tensions in the maternal blood, and you need higher hemoglobins to extract that blood through across the placenta. And then there's no need for that hemoglobin. So basically, all the red cells start breaking down, and your hemoglobin drops to a maximum of 9 grams per deciliter at around 6 months in term babies and around 6 in preterms. And then it sort of stabilizes because your erythropoietin kicks in, and it's very important to know the physiology before we can sort of go on to recognize the pathology, which is what we was taught in the first year in physiology as well. Now, going on from there, the hello.
प्रेजेंटेशन शेयर नहीं हो रही है आपकी.
Oh, sorry, I think probably. Oh. Can you see the screen now?
आपकी प्रेजेंटेशन ऑन है?
Hello, can you see the screen now?
No sir, your screen is not being shared. आपको शेयर
Okay.
करनी पड़ेगी अपनी screen.
Yeah, I thought I did that actually. But you can hear me, isn't it?
Yes. We are back. Sorry, we had some technical issues while for presenting the screen. I hope we can see the screen right now. So, Dr. Asim, can you please restart? You have to unmute your mic, Dr. Asim. Sir, you have to unmute your mic. सर अपनी आपका म्यूट हुआ हुआ है माइक फोन कर रहे हैं सर अनम्यूट कर लें अपने माइक को जी
अच्छा अब आ रहे हैं सही अब आप म्यूट
जी
भी कर दिए
सर बिल्कुल बिल्कुल आ रहा है परफेक्ट
Okay, I guess you can hear me now, and I guess we are going to see the screen. If you
यस
don't, just
परफेक्ट
let me know. So here we go again. So yeah, anemia. So, but first of all, definitions. As you know, in medicine, we're all we are very concerned about definitions because things can change especially in pediatrics with the age. So at birth, you have a high hemoglobin, but then gradually with time, it goes down and then comes up back again. So by definition, any anemia is defined as something below 2.5 percentile for that age, race, and sex. Or in other words, more than 2 standard deviations. So at birth, for example, someone will have an average of 16.5 grams per deciliter, and 2 standard deviations will be 13.5 grams. Anything below 13.5 at birth for a neonate will be classified as anemia. Now remember, from a 7-year-old, 8-year-old will have 13.5 as a normal. So it can have up to 12, 10, sort of, or 10 will be anemia, but up to 12 and still be normal. But at this age group, that will not be classified normal. So that's why very important to know what is normal and then classify your anemia and look for the causes from there and not jump to conclusions. This is a more visual, graphic representation of the hemoglobin levels as they stabilize, fall initially, and then stabilize over the period of almost 1.5 years. So as you can see, we all have very high hemoglobin at birth, which is needed to extract oxygen across the placenta from our maternal side. After birth, the lungs come in. We have a lot of oxygen, don't need that. Erythropoietin goes down, your hemoglobin starts coming down. By 6 months, you have a nadir of 9 in a term or 6 in a preterm. And then the hemoglobin starts coming up again and stabilizes around 12, 13 or so. So just to good imprint in your mind. So, for example, what do you see in your clinics or your hospitals or children who are presenting? One of the examples, we saw a 2-year-old girl who was supposed to be very pale, looked very pale when seen in the emergency, had upper respiratory tract infection, had a full blood count done, or a complete blood count, as you call it in Pakistan, done, had a hemoglobin of 5, MCV, which is your mean corpuscular volume, was 55, and retics 1%. The smear was hypochromic and microcytic. So go to a history. The very important thing in diagnostics first goes from the basics, which is history, examination, investigations, and so on and so forth. You can sort out most of the things from the history, and then you need a little bit help with investigations and the examination. So the child was a fussy eater. There was no meat in their diet. She was taking 3 pints of milk a day, which is cow's milk, eating soil when playing outside, which is pica, and you know it's what it can, what the reasons are for that. Then obviously it was found out to be iron deficiency anemia. Then we replaced some of the milk with iron-rich non-meat foods because this is a vegetarian family. They don't eat meat, plus oral iron. And the hemoglobin within 10 days from 5, it raised up to 7.5. So that's how fast you can cure a child who has iron deficiency anemia. This is just a very quick thing to tell you that you have a lot of iron even in non-meat products. Your soybeans, lentils, spinach have quite a bit of iron content in them. And your processed foods, the baby foods, if you see, they don't have much iron. So please try to go to natural foods available in our society rather than going for tin foods and stuff, which sometimes is fashionable. So, what we have to look at the history again. What do we identify? The history tells us a lot about what sort of anemia it is. If it happens in neonates and young infants, usually it's immune hemolytic disease, or it can be an infection or hereditary disorders. These are the ones which are the bulk of etiology in neonates and in young infants. Then around 3 to 6 months of age, if you have anemia presenting, even before that the child was fine, usually a hemoglobinopathy, because now the hemoglobin is the you have to go into details, and it will be a bit off the time. But just to keep in mind, these are the ones which things like thalassemia and stuff present. Nutritional iron deficiency, unlikely cause of anemia before the age of 6 months in term infants, because you'll usually have stores for term infants. The last trimester is when the accretion of iron happens in the fetus, and you'll usually have enough iron there, unless the mom is very deficient herself. In older children, acquired cause of anemia more likely, especially iron deficiency due to either dietary issues or blood loss. Then, if you see the anemia is in a particular sort of in a sex group, either female or male, depending on that, X-linked ones in girls, G6PD deficiency, X-linked sideroblastic anemia in boys, sorry. In girls, they can sometimes present, but because of hopefully the better second X chromosome and the lionization hypothesis, you'll find they will do well most of the time. It's the boys who, if they have the G6PD deficiency, even a single gene, because of the next Y chromosome, it will present as a hemolytic anemia. Then race and ethnicity, you have to ask where are they from. So, for example, hemoglobin S and C, sickle hemoglobin. Now, I remember from my time in Karachi when I was working, we would find a sickle cell in Makranis, who are from most Balochis and Makranis, those areas. We sort of didn't see any sickle cell apart from that. Obviously, we are there for a short time, but just to know the ethnicity. If it's anemia, it's a Makrani person or it's an African person, you have to think in your mind, because as the famous statement goes, you only see what you look for. So if we have something in our mind, we'll look for it. Otherwise, you'll miss it. Then thalassemia syndromes are common in Mediterranean area, Southeast Asian descent. So very common in Pakistan, here in Dubai as well, and in many areas. We will just show you the map as well. Also, G6PD deficiency more common in some groups as well, in some race groups, as we have listed: Filipinos, Greeks, Jews, Sardinas, Kurds, and some black populations. We have to listen to the symptoms as well. If there is a change in urine color, there's hemolysis, intravascular hemolysis, the hemoglobin is coming out. If there's jaundice, icterus, then again there's hemolysis going on. This also just hemolysis, as opposed to an iron deficiency or something due to decreased production of red cells. If we have bloody stools, and then there's hematemesis, severe epistaxis, bleeding, then this might be just from the blood loss, iron deficiency. And infections obviously suggest an infectious etiology, but again, it can be an infection on top of an iron deficiency, which is quite common. So again, keep in mind about 2 or 3 things. Then prior episodes of anemia suggest an inherited disorder. If especially it has been a recurrent thing, that means it might be an inherited disorder. Then anemia in a patient with previously documented normal CBC suggests an acquired etiology. So if it's all fine, something happened now, something is there, rather than congenital, might be acquired. Then hyperbilirubinemia in the newborn suggests a hemolytic etiology. And microcytosis at birth suggests a chronic intrauterine blood loss or thalassemia. Because generally speaking, microcytosis, you'll think iron deficiency anemia. But in a newborn, it's because there's iron should be fine, it is not really the reason. So you have to think of thalassemias, either alpha thalassemia traits, which are very difficult to detect on ordinary testing, unless you do genetics, or it's intrauterine blood loss. Again, dwelling on the history, if you have to look for renal disease, malignancy, any autoimmune diseases, all these will give you anemia of chronic illnesses. Then drugs and toxin exposure, exposure to paint, home preparations, lead toxicity. If they have had fava beans, any oxidants, quinine, any septrin, any of the lists of things which actually in a G6PD deficient child with caught hemolysis, you have to take good history of them because it's incumbent upon us to do that. Then any family members with jaundice, gallstones, splenomegaly suggest a hemolytic anemia. Again, things like spherocytosis, etc. In the diet, very important, especially if you want to identify iron deficiency of the diet, you have to check for, did they have low formula? Did they have cow's milk before 1 year of age rather than breast milk? And then is there excessive milk intake or poor intake of iron-rich foods? Also, we have to look into travel history, the way they have traveled. If you're in an area like in UAE, for example, where there's almost no malaria, then if someone comes with malaria or something, it must be, and we see that, and those coming from India or Pakistan, you'll find some of them will come and end up in malaria here. Developmental history, very important, because your vitamin B12 deficiency, vancomycemia, is associated sometimes with developmental delay and iron deficiency itself. Physical exam also, these are all the things listed because we are a bit short of time. I'll not go through the details, but hyperpigmentation, petechia, purpura, to look for other things as well. Jaundice, as we discussed already, in frontal bossing, malar prominences in thalassemias, your glossitis, anglostomatitis, iron deficiency, B12 deficiency, and your shielded chest and endowment black fat. Just a little bit of how the thalassemia, I'm sure you all recognize the thalassemia facie because it's so common in Pakistan. And then colonychia, atrophic glossitis, but colonychia will be a bit later on. Again, a list of other things that might come up, but we'll not sort of dwell a lot on that details. So what do we do? Fine, we have got a child, you got a history, you have something in your mind, maybe it's an iron deficiency. What is the next step we want to do? Or even if he looks very pale, to get to the definition of anemia, we have to at least do a simple test. So these are very simple tests, the full blood count or the complete blood count. You do the indices and the lowest MCV, remember, because all your anemia is classified according to the volume of cells. So the lowest MCV is 70 plus age in years, very easy to remember. Otherwise, nowadays you have all the ranges next to your results as well. Then peripheral film, very important, and a retic count. So these are basic 4 tests that you can do and find out most of the causes of anemia. This is what your film will show you. So if it's a normal cell, if it's a macrocyte, again, this is a macrocytic sort of anemia. If you have microcytes, it's a microcytic anemia, more common with iron deficiency, and elliptocytes, fragments. So these all tell you what other cells they are. Sickle cell will look like sickle. Elliptocytes, spherocytes will be spherocytosis, elliptocytosis, and some of the other hereditary hemolytic disorders. So what do you do? Now, the best thing, especially in Pakistan, India, and all the underdeveloped countries and developing countries, it is iron deficiency unless proven otherwise. So there's no one can prove you wrong if you have a child with anemia to start iron, because most of our populations are iron deficient. Unless, so the red flags are these. So if these red flags are there, then you think about other things as well. So wrong age, an adolescent boy, anemia, a bit unlikely to be iron deficient. Can be and might be in our environment as well. But generally speaking, a bit unlikely. Organomegaly, lymphadenopathy, a bit unlike to be iron deficiency. Iron deficiency will not cause hematosplenomegaly. Can cause a little bit of lymphadenopathy, but will not cause. If you have a big spleen and liver, something else is going on. With the lymph nodes, you have to start thinking of other things, including leukemias and lymphomas. Severe anemia, to some extent, less than 8, it will be up to 8. But yes, in some severe cases, we have seen less than 8 as well. But generally speaking, a very severe anemia, you have to investigate other things as well. A normocytic anemia or low RDW, will come to the RDW as well, with the red cell distribution, unlikely to be iron deficiency anemia, because iron deficiency will have microcytes and will have a high RDW. Failure to respond to therapeutic iron, you have given an iron trial, it's not responding, you need to think, maybe it is something else. And then symptoms suggestive of hemolysis, jaundice, abnormal current, this is hemoglobinuria, it's not iron deficiency, you have to look at other causes. Family history, if there's a recurrence in the family history of other persons having anemia as well, a bit unlikely to be iron deficiency. Having said that, iron deficiency is the most common etiology of anemia globally, around the world, not only in Pakistan. So this figure just tells you it's not only iron deficient, there are stages of iron deficiency. So you have a normal set of indices, as you can see on the left-hand side, normal hemoglobin, everything. So first thing which happens is actually what you call iron deficiency, iron depletion, and not really deficiency. So the first thing which will fall is your ferritin, serum iron binding capacity and stuff. Now, if you go on, you'll find your iron deficiency then you have your iron deficiency without anemia, and that will happen with your ferritin coming down, your iron starts coming down, even though it was not. Now you can find it, and but still your total iron binding capacity is fine, and your transference are approximately fine, not bad. And then you have the full-fledged iron deficiency anemia, where your hemoglobin drops. This you find on your full blood count. The others you might not find on your full blood count. So that is why it's important that just to see, sometimes you have a normal hemoglobin, but the child is iron deficient. If he comes from a family and your history shows you that they are poor on iron, better might be to give them some extra iron. So overall, in a one sort of set picture, everything is iron deficiency except if you have red flags. So if you have no red flags, you give an iron trial. Response over a gram of hemoglobin in a month, yes, you continue for 3 months to correct the stores, and then counseling and prophylaxis and all that. Obviously, if it doesn't, then you again come back to square root. Something is wrong. Something else might be there. If there are red flags, as we discussed in the previous slide, then you do your CBC, your MCV, your indices, and you check your Menser index, which will come in the next slide. So you will be classifying your anemia into either microcytic, which confirms your iron deficiency most of the time, and then you have to search for etiology for iron deficiency. Is it from the loss or intake problem? Is it intake problem or loss problem? And you can do electrophoresis, because sometimes your alpha thal traits can also present just with the iron deficiency picture. And then you check for your iron absorption, and consider iron, IV iron, if you have a problem with iron absorption. Then your normocytic anemia, you have either a decreased production problem from infections, your parvoviruses. Many of the viruses will actually make your bone marrow suppress a little bit, and then after 2-3 weeks they'll come up. Is there organomegaly? No organomegaly, because maybe something else is there. You have to look for leukemias. You have to look for, that's why you have the bone marrow aspirate listed there. And then your increased restriction, which is hemolysis. So your blood fill becomes very important. Your G6PD, osmotic fragility, but that's not available everywhere. And your Coombs as well. Your Menser is your MCV divided by your RBC count. If it's more than 13.5, it points toward iron deficiency. If it's less than 11.5, it points towards thalassemia. So failure to respond to iron, maybe there's continued bleeding. So you have to check your stool for either visual blood or your occult blood. Maybe there's non-compliance. So you have to make sure.
Dr. Asim, sorry to interrupt you, but we are running a little short of time.
And maybe it's a wrong diagnosis. If there's a thalassemia trait, it will present as a iron deficiency with microcytic anemia, but you giving your iron will not solve the problem. And your mixed deficiency either with vitamin B12, folate, and malabsorption. So this is some of the, I think we have less time. Again, and the last one to tell you, if you did everything, still they're not getting better, and it doesn't look like anything else as iron deficiency. Sometimes it can be a TMPR SS6 mutation. Now, the reason I mentioned is we found a family from Mardan who was here in Dubai. We had the opportunity to do genetics, and I found out that this is what two of the children had. Both parents were carriers, and both patients were homozygous for the mutation. I'm not saying you do genetics, not at all, because it's very expensive. We have the luxury of it here. You don't have, but use our knowledge and our luxury to apply it there. So if you have people coming from Mardan, on from the north, and they are not responding to your iron supplements, think about genetics as well. And the non-cyclic anemias, again, protection we all know, the bone marrow failures from viral infections, anemia of chronic diseases, destruction mainly from, so you have to, the mnemonic is hemoglobinopathies, enzymopathies, membrane defects, autoimmune. We have already discussed this, and this has gone through. So I'll just, because it's short of time, we'll just go through. So hemolysis, in hemolysis, you will have, again, very common in our area, beta thalassemia. We have normocytic anemia, elevated retic count, elevated bilirubin, elevated LDH, haptogulamins, and you have blood positive with no RBCs because there's hemoglobinuria. You have to do a blood film and do some specific tests, Coombs test, G6PD, hemoglobin, to rule out your common hemolytic anemias. The common ones, sickle cell anemia. Here, even in Pakistan, like I said, you'll find many. You have spherocytosis, and this just gives you the details of that. You have G6PD deficiency. You have to avoid all the drugs and fava beans and naphthalene mothballs. Thalassemia, like I told you earlier, we show you a graph. This is where the thalassemia distribution is all over the world, together with some of the other hemoglobinopathies. And obviously, if it's very severe, it's a shade of different intensity. In the very severe form, you have hydrocephalus, incompatible with life, and then you have the carriers and major and minor. We'll not go through that. And
Thank you so much, Dr. Asim, for a wonderful presentation in such a little time. We had some technical issues, but it was really nice listening to you. We will be taking the questions at the end of the session. Thank you so much for your talk and your time. We are really grateful. So moving forward, we will be going to our next talk. Our next talk will be by Dr. Sadaf Altaf. Dr. Sadaf Altaf is a graduate of Dow Medical College and trained at Mayo Clinic, Rochester, USA. She joined Khan University Hospital in 2014. She is the program director of the Pediatric Hemonc Fellowship and is working on establishing pediatric bone marrow transplant services at her institution. Her areas of research interest include bone and soft tissue sarcomas. Dr. Altaf is also the co-chair of SIOP Global Health Supportive Care Working Group. Her vision is to engage physicians in low middle-income countries to connect with mentors in high-income countries, providing intellectual support to improve care of children suffering from cancer. Dr. Sadaf will be giving talk on chelation therapy for transfusion-dependent thalassemia major, a topic which needs the most attention once a child is diagnosed with thalassemia besides adequate transfusion practices. So over to you, Dr. Sadaf.
Everyone, my name is Dr. Sadaf Altaf. I'm a pediatric hematologist, as mentioned before, and I am really, really honored to be talking about something that is very, very close to my heart, which is the management of transfusion-dependent thalassemia. And I'm very grateful to the organization committee of ICON 2022 for giving me this opportunity to present. The title of my talk today is Chelation Therapy for Transfusion-Dependent Thalassemia. And I do not have any financial disclosures. There are three major objectives of my talk today. Number one is to be familiar with the differences in iron overload between transfusion-dependent and non-transfusion-dependent thalassemia. Second is to review complications of iron overload. And the third objective is what is the current therapy for iron overload, and we will review some literature about it. Before I start, I would like to quickly do a pre-test with the audience so that the audience is clear on their understanding of terminology and the requirements for management. Question number 1 is, what is the most important complication of iron overload in transfusion-dependent thalassemia major? Number 2 is, liver is the target organ in non-transfusion dependent thalassemia due to increased iron absorption from the gut. Is that true or false? And the last question is, a T2 star value of less than 10 milliseconds indicates a healthy heart. Is that a true or false statement? So keep these questions in mind when we go over the talk. So very quickly, what is beta thalassemia? I think everyone is familiar with this, that it is the decreased synthesis of beta subunit of hemoglobin. There is hypochromic microcytic anemia, and the peripheral blood smear shows abnormal cells with nucleated red blood cells. And there is reduced amount of hemoglobin A on hemoglobin analysis. The picture on the right over here really shows a very good description of how alpha thalassemia remains the same throughout the human life. Alpha hemoglobin remains the same, whereas beta globin chain essentially is non-existent in utero and starts developing after birth around 6 months of life. So that is really the basis of why generally beta thalassemia presents at a later stage in life, not right at birth, versus alpha thalassemia. So there is severe anemia and hepatosplenomegaly. This is diagnosed within the first 2 years of life. And without treatment, affected children have severe failure to thrive and shortened life expectancy. Regular transfusions are necessary for survival. An amount of red cells transfused such that pre-transfusion hemoglobin should remain more than 9 grams per deciliter, with transfusions every 3 to 5 weeks, depending on how the child clinically behaves. But it is really important for us that we understand the clinical classification and the terminology. So what is transfusion-dependent thalassemias? Where the child or patient is not capable of producing sufficient hemoglobin for survival. Whereas non-transfusion-dependent thalassemias are such that they can require transfusions sporadically or regularly, but not for their entire life. I really would urge all of you to be familiar with these classification terminologies, because most of the talk will be based on these two terms. So why does iron overload happen in thalassemia or a hemoglobinopathy? So there are a number of reasons. The first one being that we are actually transfusing the patient. The other one being that there is ineffective erythropoiesis, which means that the red cells that are being produced are broken down constantly. As a result of which, what happens is that when the red cells are broken, all the iron theoretically is supposed to be taken up by the macrophages. And then what happens is that the transferrin receptors bind the free iron in the body. What happens here is, as you can see, that there are very few transferrin receptors that are looking free, very few. And the percent saturation tends to be really high in patients with thalassemia because there is a lot of iron that the transferrin has to bind. Now, these blue dots are the non-transferrin bound iron, all right? And this is what causes all the toxicity in iron overload. As you can see, this non-transferrin bound iron is going inside the liver and inside the heart. It also goes inside the bones and the endocrine system. Over here, you can see that there is iron that's being absorbed by the gut. And that iron that is being absorbed by the gut works in a similar manner in causing toxicity within the body. Why is it being absorbed by the gut? Because in non-transfusion dependent thalassemia, pathophysiologically, there is an increased absorption from the gut, which is then toxic to the body. So keeping in mind that the two types of thalassemias, which is transfusion dependent and non-transfusion dependent thalassemia, this diagram over here also shows what are the clinical implications of having excess iron in the body. And what it does is that it affects the whole body. If you look at transfusion-dependent thalassemia, around 200 to 250 milligrams of iron is being given every time a patient is transfused. Now, all of that extra iron, iron overload is what this describes, IOL, is going and getting deposited in the endocrine organs, heart, causing liver fibrosis, eventually leading to tumors and cancers, causing deposition in the pancreas, leading to diabetes, also causing ovarian and testicular dysfunction, similarly bone disease. Now, similar sort of issues also happen in non-transfusion dependent thalassemia, but in a different sort of way. For example, there is a lot of iron absorption which is causing liver dysfunction in non-transfusion dependent thalassemia, versus a lot of cardiac dysfunction that happens before liver dysfunction in transfusion dependent thalassemia. So the four major organs that I mentioned, there are other organs that are also affected: heart, liver, bones, and endocrine organs. Cardiac complications are the major problems, and it is the target lethal organ causing 70% of deaths in transfusion-dependent thalassemia. Iron deposition happens in ventricular walls. The increase in the heart size, first-degree heart block, pericarditis, and congestive cardiac failure also happens. After the onset of heart failure, duration of life is less than 3 months, and cardiomyopathy may be reversible once chelation is intensified effectively. Similarly, endocrinological complications such as hypothyroidism, hypoparathyroidism, impaired glucose intolerance, and vitamin D deficiency and insufficiency happen. Now, bone disease and skeletal complications, major problem is osteopenia and osteoporosis, and it is the common cause of morbidity. About around 40 to 50% of patients with transfusion-dependent and non-transfusion-dependent thalassemia later on in life. Hepatic fibrosis due to iron overload is particularly common in patients with non-transfusion dependent thalassemia, and hepatic fibrosis causing hepatocellular carcinoma is a major problem. These are the most updated guidelines for the management of transfusion-dependent thalassemia, which are published by the Thalassemia International Federation. They are updated every few years, and this is hot off the press. What is the need for chelation? How to get rid of all of that excess iron? So what the guidelines suggests is whenever, for a patient who's of 20 kilograms, if the pure red cell volume that has been transfused around 2,000 to 4,000 mils per year, or if the daily iron given is around 6.3 to 12.6 milligrams, then that patient is ready for chelation. And that is updated, or that is sort of goes up as the patient's age goes up accordingly. So there are three major medications for chelation: desferoxamine, which is identified as DFO, deferasirox, which is identified as DFX, and deferoperon, which is identified as DFP. These are the three major drugs used universally for decreasing iron overload in the body. How do you measure iron overload? So serum ferritin is an easy test that is done. It is the most commonly used parameter despite its large limitations, but it does give a rough assessment of long-term status of iron overload. I think when one uses serum ferritin, then it is important that a trend is used and it is serially monitored. A ferritin that is consistently higher than 2,500 micrograms per liter is associated with increased risk of cardiac and endocrine disease, and serial monitoring and elevation is the key here. Liver biopsy used to be the gold standard when more than 7 to 15 milligrams per gram dry weight is associated with increased complications, but due to its invasiveness, it is not currently used. Whereas MRI of the liver and heart is now becoming the gold standard. R2-star MRI is done to assess liver iron content. I'm not aware of anybody doing this in Pakistan, but T2-star MRI is being done routinely at Khan University Hospital for assessment of iron overload in the heart, and this is repeated every 6 to 12 months. So when we classify chelation therapy, it is classified into 3 major types: prevention, rescue, and emergency therapy. Prevention therapy, the goal is to maintain safe levels of body iron at all times, whereas rescue therapy is when iron overload has already happened, and emergency therapy is when heart failure has set in due to iron overload. Current therapy of iron overload is typically not used in children less than 2, but cumulative transfusion load of 120 mils per kilogram, once that has happened, then current therapy or iron chelation therapy should be started. I mentioned the 3 drugs in the beginning. It is a standard iron chelator since the 1970s. It is licensed for use from age 2. It binds iron tightly, and it causes iron to be excreted in the urine. It is given as a long parenteral infusion with a short half-life. 30 to 60 milligrams per kilogram per day is generally the dose. Asundra or deferoxamine, which is inactive. Deferoxamine is inactive orally, and which is why it has to be given subcutaneous as an overnight infusion 5 to 7 nights per week, but it can be administered IV as well. Major side effects are irritation at the site of infusion, ocular and auditory disturbance, growth retardation and skeletal changes, and allergic reactions. Deferoperone, it's an orally active compound licensed for use from age 6. The dose is mentioned over here, but it has some side effects such as arthropathy, increased LFTs, and hepatic fibrosis. Deferocyrox, which also comes as the name of Asundra, or Exjade, is an oral iron chelator. This is licensed for use at age 2 in the USA as a first line, whereas in Europe it is used as a second line if desferol fails. Long half-life, and it's once daily dosing, which is ideal for ease of administration and compliance. Can cause abdominal discomfort, renal impairment, and increased liver enzyme. It is the preferred drug because it is taken once a day for prevention therapy. Convenient dosing and monitoring of liver and kidney function is required. Combination chelators are very important, and desferol with deferocyrox is a novel combination of 2 oral chelators that has been given for iron overload. There are guidelines published by the Thalassemia Federation of Pakistan, and these are totally based on serum ferritin values, and combination therapy is suggested if serum ferritin value continues to rise. Deferocyrox is the agent of choice to be started at age 2 years. These are some of the international guidelines that I just wanted to put up here, where along with age, they're using something different. For example, Australian guidelines use cardiac T2-star. Similarly, Canadian guidelines use serum ferritin and liver iron content to monitor therapy and to tweak therapy. US guidelines use serum ferritin, liver iron content, cardiac T2-star, all 3 in terms of modifying therapy. And this is the UK guidelines. So combination therapy is very important for non-transferrin bound iron to be taken out of the body. And single agent therapy clears a fraction of non-transferrin bound iron in the plasma. So transient removal of redox active subfraction of non-transferrin bound iron is termed labile plasma iron. So this is the post-test. I hope that the brief talk that I did helped you all answer the question. So question number 1, what is the most important complication of iron overload in transfusion-dependent thalassemia major? So it is cardiac toxicity, whereas liver is the target organ in non-transfusion dependent thalassemia. That is the true answer. And then T2-star value of less than 10 milliseconds indicates an unhealthy heart. So this is a false statement. In summary, thalassemia therapy is associated with significant morbidity. Cardiac, hepatic, skeletal, and endocrine complications occur. Preventative therapy must be initiated for lower morbidity for transfusion-dependent thalassemia. Surveillance and monitoring is required to prevent complications. Our patient population has significant iron-related toxicity. Combination chelation therapy is one way to effectively reduce load, overload, and decrease toxicity. Combinations can be chosen based on on the number of comorbidities and tolerance of adverse events in individual patients. And one big factor to overcome in our setup is the cost of chelation. Thank you very much. And I'm happy to answer any questions and comments that can be shared with the moderators. Thank you.
Thank you so much, Dr. Sadaf, for an enlightening talk. It was a wonderful talk and a much needed one. We will take the question and answers at the end of the session. The attendees are welcome to ask any questions. They can drop in their questions. Our next talk will be by Dr. Fatima Ambreen Imran. Dr. Fatima Ambreen graduated from Dow Medical College, followed by a fellowship in pediatrics from Civil Hospital, Karachi, Pakistan. At the end of pediatric training, she had joined Children Cancer Hospital and developed special interest in the care of children with cancers. She did her fellowship in Peds Hemonc from Children Cancer Hospital in 2017. Children Cancer Hospital became a part of Indus Hospital. She gained valuable experience over the next 3 years, and she is currently working as a consultant in pediatric oncology at Indus Hospital and is taking care of children with abdominal tumors. She will be enlightening us on an approach to abdominal mass, and I'm sure she will give a good overview on how to approach children with abdominal masses. So over to you, Dr. Fatima.
Ambreen, working as a pediatric oncologist at Indus Hospital. Today's discussion of my topic is approach to the abdominal masses in pediatric age group. I have no disclaimer for this discussion. This is just for an educational purpose. So the overview of the today's discussion is based on when to suspect a malignancy in a child presented with an abdominal distension with palpable mass with other associated signs and symptoms, and then how to approach the abdominal mass according to the abdominal quadrants, and then how to approach a patient with detailed history and examination to make possible differential diagnosis, and then approach-wise investigation to reach the final diagnosis. And in the end, we will discuss the details about some common abdominal malignancies. So when to suspect a child who is presented with maybe with or without abdominal distension associated with other symptoms. The other organ dysfunctioning symptoms are mainly due to the pressure effects or the mass effect of the abdominal mass. They may be of different types, and it depends on the site of the mass that arises within the abdomen. It may be associated with genitourinary dysfunctions, associated with gastrointestinal symptoms, and sometimes the child may present with neurological symptoms if the mass is presented in the lower abdomen, in the presacral region, or in the paravertebral region in abdomen that causes the spinal cord compression, leads to the neurological symptoms. And the neuroblastoma is the commonest malignancy in the childhood, and it is presented with different neurological symptoms, even without a palpable mass in the abdomen. And sometimes the children is presented in an acute condition with distended, tense abdomen, and this is a pediatric surgical emergency, and sometimes it may need exploratory laparotomy for the cause. So what next? When we are suspecting a patient presented with abdominal distension with or without a palpable mass, mainly the children are presented to the pediatricians or to the pediatric surgeons, and they make their differential diagnosis of infection, like and other causes like constipation, and non-malignant disorders like renal disorders, congenital anomalies of the kidneys. So they have to be managed appropriately according to their differentials. But when you have a high suspicion of malignancy in a child with abdominal mass, you should refer these patients early and the proper referral to the pediatric oncologist for early diagnosis and prompt treatment without a complication of the advanced stage at late presentation. The most important thing is the follow-up of the same patient if the symptoms were not relieving with your diagnosis and symptomatic treatment. So you must think about the malignancy in your differential. And after proper workup, when you have a high suspicion of abdominal mass malignancy, then the patient should be referred to the pediatric oncologist for further management. So for the basic approach to the abdominal masses in pediatric age group is mainly based on the possible etiologies that presented with the abdominal mass, the specific site of the abdominal mass in the abdomen, and it depends on the underlying anatomical structures in the abdominal cavity, as well as it is based on the clinical presentation of the child, especially the age when the child is presented and the other associated symptoms. On the basis of these, you may have a differential diagnosis of renal tumors if the mass is arising from the kidney, or you may have the differential diagnosis of neuroblastoma from the if a mass is arising from the adrenal gland, or if the mass is arising from the liver. So you may have the commonest differential of malignant liver mass in pediatric age is hepatoblastoma. And lymphoma can be presented with the abdominal mass in any quadrant of the abdomen. If a child presented with a lower abdominal mass, then you have a differential diagnosis of neuroblastoma, germ cell tumors, either gonadal or extragonadal, and other less common differentials are the sarcomas, including rhabdomyosarcoma and Ewing sarcoma. Sarcomas are usually presented in pelvis with a soft tissue mass that may be identified on examination, and the pelvic masses are usually associated with genital dysfunctioning and constipation, and there may be altered bowel habits. So this is the main approach according to the quadrants of the abdomen when the mass is palpable in different size. The important consideration is the age of the presentation of the child at which the child presented. In neonate age, a child is presented with abdominal mass. So the most commonest differential is the neuroblastoma. So neuroblastoma can be presented at birth or within the neonate or during infancy. In infants and in other age groups, other possibility of malignancies with abdominal mass include Wilms tumor and hepatoblastoma and other less common malignancies. Some of the abdominal masses, malignant masses especially, are more in boys than in girls. And the history of the presenting complaints, when the mass is presented and how long the duration of the symptoms, is the mass appearing gradually increase in size with long duration. So the mass more likely to be benign in nature. If there's a short history of presentation of weeks or days with progressive increase in the abdominal mass, so most likely the cause would be malignant tumor in the abdomen. You have to exclude the history of trauma. If there is a history of trauma with acute abdominal distension or a palpable mass, which may be a surgical cause, you have to early identify the cause in these cases which are associated post-trauma. In systemic review, other system organ review on history is very important, which may give you the clues about the other associated symptoms with the primary abdominal mass that will help in making differential diagnosis. These organ systems symptoms are like in gastrointestinal symptom, there may be history of nausea, vomiting due to a mass effect of the mass in the upper abdomen. Abdominal distension may lead to the abdominal pain, uh, and altered history of bowel habits like persistent diarrhea, as in some cases of neuroblastoma, the child presented only with a history of persistent or recurrent diarrheas without any palpable mass. Then investigation, you would identify the abdominal mass that is not identified on the palpation. So the history is very important. In some cases, patient presented with constipation due to the bowel obstruction, either partial or the complete. If there is complete obstruction of the gut, it may lead to an acute abdominal condition. Sometimes child presented with blood in the stool, and it is important to evaluate the cause of the blood in the stool, which may be associated with abdominal malignancy if the child is presented with abdominal mass. Other system organ symptoms include genitourinary symptoms with altered urinary habits like increase or decrease urination, burning micturition, and presence of blood or pus in the urine that may be associated with secondary infection. And in case of Wilms tumor, sometimes child presented only with a history of hematuria uh, with incidental palpation of a painless abdominal mass. Other symptoms include neurological signs and symptoms, especially in case of neuroblastoma. Sometimes patients presented with just a history of abnormal movements of the body and the eyeball, and that is called as opsomyoclonus. It's a paraneoplastic syndrome that is associated with neuroblastoma. And sometimes child presented with abnormal gait, with ataxia, abnormal behavior, and sometimes signs of cord compression may be present with pelvic masses with cord compression. Other symptoms that can be told by the parents or that can be identified on the examination, like the bone pain, progressive history of pallor, and evidence of bleeding from any side of the body, or evidence of bleeding on the skin like petechia, bruises, will give you the impression of the disease is metastasized to the bone marrow in a child with abdominal mass. Other constitutional symptoms that are associated with a chronic illness or with a malignant illness include fever, malaise, weight loss, and the malnutrition, and all these leading to the secondary infections in these patients because they are immunocompromised. Birth history is very important in prenatal screening. If there is identification of an abdominal mass, especially the adrenal side or the lower back mass on the prenatal ultrasonography, will give you the clues that the child may present with the congenital tumors, and usually these tumors that are presented in the neonatal age are benign in nature. And sometimes the child have the history of mother had ultrasound finding of poly or oligohydramnios, and this is maybe associated with non-malignant renal disorders or congenital kidney anomalies. And birth history is very important, like low birth weight, prematurity is especially associated with hepatoblastoma, and it with increased risk. Other anomalies that are presented at birth, like the Weger syndrome, Denny's-Drach syndrome, and Backward-Wiedemann syndrome, these syndromes have a very high risk of development of Wilms tumor. So these children should be on regular periodic screening for early identification of any renal mass. Past medical, surgical, and previous history is treatment history is very important, which can give you the clues about the differential diagnosis. So the complete physical examination, especially including the blood pressure that may be raised in case of Wilms tumor, neuroblastoma, or pheochromocytoma. And the anthropometric measures and the growth parameters are very important because especially the malignant tumors or rapidly growing tumors are usually associated with severe malnutrition, and that would lead to the further complication of the malignancy. And detailed systemic and abdominal examination will give you the important clues about the site of the abdominal mass, and that would help you to make the differential diagnosis. Other physical findings, especially the signs of the syndromes, and the genital examination is very important to identify any perianal abnormal perianal orifices or ambiguity of the genitalia and testicular asymmetry. So for evaluation, how do you evaluate a patient who presented with an abdominal mass? After complete detailed history and examination, you have some differential diagnosis in your mind according to the site of the abdominal mass presentation and other associated symptoms. Most commonest differential malignant abdominal mass in the pediatric age group is neuroblastoma, then Wilms tumor, hepatoblastoma, germ cell tumors, lymphomas, and sarcomas. These are the main commonest differentials in a child who presented with abdominal mass. So after making differential diagnosis, you have some investigation which may be which depends on your differential diagnosis, and you have to do the investigation approach wise. First of all, you do the hematology, the CBC with the differential counts, and CBC shows if it shows anemia, cytopenias, or decreased platelet count, that may be associated with a secondary bone marrow involvement in case of a malignant abdominal mass. Peripheral smear review is very important if there are presence of atypical lymphocytes or the abnormal lymphoma cells in the peripheral blood. That will give you the differential of leukemia or lymphoma. In these cases, you have to do the complete biochemistry along with calcium, magnesium, phosphorus, uric acid, urea, especially for the tumor lysis syndrome. And other labs, including the coagulation profile, because you have to reach a definitive diagnosis. For that, you have to check the coagulation profile to prevent any post-invasive procedure bleeding. Chest X-ray is very important to do in first because if there is a presence of mediastinal mass along with abdominal mass, so you have to manage the patient with very cautiously with proper position due to the mediastinal mass, because it can lead to the sudden airway collapse, and that may be fatal to the patient. Tumor markers are very important, and that will give you the important clues about your differential diagnosis. In case of neuroblastoma, increased urinary levels of vinyl mandelic acid and homovinylic acid before your biopsy report. If these levels are raised in the urine, that will give you the clue about the differential of neuroblastoma. Other markers in the plasma include plasma metanephrine and non-metanephrine levels, which are also raised in neuroblastoma and also in pheochromocytoma. Ferritin and LDH are just a prognostic marker for neuroblastoma. If they are high from their upper normal limits, so associated with the poor prognosis of the disease. And in case of hepatoblastoma, alpha-fetoprotein and beta-SCG may be raised, which give you the clues that if the child presented with abdominal mass in the right upper quadrant, and on investigation, the mass is arising from the liver with high EFP level, so you have a differential of hepatoblastoma first in your mind. And these markers like AFP, beta-HCG were also raised in case of the germ cell tumors. Either they presented as an abdominal mass or a testicular mass in a male child. Non-Hodgkin lymphomas are sometimes presented with primary abdominal mass, which may arise from the gut or from the intra-abdominal nodes. LDH is a prognostic marker for non-Hodgkin lymphomas. In case of Hodgkin lymphoma, usually Hodgkin lymphomas are presented with peripheral lymphadenopathy, but sometimes child may have enlarged intra-abdominal lymph nodes or visceromegaly, so the child can present it with abdominal mass. ESR is just a prognostic markers for Hodgkin lymphoma. And the rarest tumor in the pediatric age group is the ovarian carcinoma. The tumor markers is CA125. It may be raised at presentation. Other rarest tumor in pediatric age group is the adenocarcinoma. It is mainly the disease of adults, and the tumor markers is for adenocarcinoma is carcinoembryonic antigen. If it is high at presentation, it will be a poor prognostic sign for the treatment. So the workup for the primary side, if the child presented with an abdominal mass, you will do the X-ray abdomen, erect or supine, especially in cases of child with acute abdomen. And ultrasonography is very important or very least expensive investigation that will give you the important clues about the site of the organ from the masses arising, and it will give you the details about the mass, either it is cystic, solid, or so you have your differential diagnosis in your minds. The cystic tumors are usually benign, or the solid tumors, highly malignant looking on ultrasound, are malignant.
Sorry to cut you, Dr. Fatma, in the middle. Thank you so much for a very informative talk. We are running short of time, and we will take the questions at the end of the session, and we'll be happy if you answer them. Our next talk is on infections in immunocompromised children by Dr. Samina Junejo. Dr. Samina Junejo is a pediatric infectious disease consultant at Indus Hospital. She did her MBBS from LUMS and completed her training for PEDS and infectious diseases from AKUH. She has been extensively involved in managing pediatric COVID infections at Indus. Her special interests include immunodeficiency and TB infection, and has several research papers to her credit, which are related to immunodeficiency, pediatric infections, and COVID. She will be giving a talk on infections in immunocompromised children, something that we see every day as peds oncologists, and is a major cause of morbidity and mortality in our children. So over to you, Dr. Samina.
Compromised host is a person who does not have ability to respond normally to an infection due to impaired, weakened, or defective immune system, predisposing him to the infections, often life-threatening infections which wouldn't otherwise occur. It can be congenital or acquired. In congenital conditions, syndromes, B cell defects, T cell defects, and combined B and T cell defects are included. On other hand, malnutrition, HIV, cancers, and immunosuppressive drugs causes the secondary immunocompromised status or state. Coming to our main topic, cancer and immunosuppression. Cancer and chemotherapy predisposes the patient to the infection, results in multiple things, which includes disturbance in the treatment regime, prolonged hospitalization, increased cost of healthcare, and reduced survival. Infections remains a primary or associated cause of death. Bacteria are on the top, followed by fungi. So there are multiple factors which increases the risk of infections. Neutropenia is on the top, and it can be secondary to chemotherapy, radiation therapy, bone marrow infiltration with the tumor, or drugs. Second most common cause or the risk factor is the anatomic barrier. if the destruction of anatomic barrier occurs, which can be secondary to chemotherapy, radiation therapy, vascular catheters, urinary catheters, percutaneous endoscopy, gastrostomy tubes, or other devices, it puts the patient on the risk of infection. And there are multiple procedures and devices which also increases the risk of infections. And on other hand, steroids, diabetes, HIV, autoimmune diseases, extremes of age, nutritional status, prior antibiotic exposure also predisposes the patient to the infection. So whenever the patient comes with the suspected infection, you have to go through the detailed history, and you have to ask about the sign and symptoms and suggestive of focus of infection, including symptoms regarding URTI, UTI, GI infections, skin infections. And the second most common thing which you have to look for is the indwelling catheter. And if you know the previous positive cultures, it will help out you in deciding the first initial empirical therapy. When you are done with the detailed history, then you have to send blood workup, which usually includes blood testing to see the bone marrow, liver, and renal status, inflammatory markers, including procalcitonin and CRP, blood cultures, and urine cultures. Blood cultures should be sent centrally as well as peripherally, both simultaneously. And after that, start empirical antibiotics. If patient is not improving after 72 hours of empiric antibiotics, then you have to go for HRCT and bronchoalveolar lavage, especially for the fungal workup. So as we discussed, bacteria are on the top in causing infections, and followed by fungi and then viruses. Coming to the bloodstream infections, as we discussed earlier, neutropenia is the major factor in cancer patients for the infections. Neutropenic fever is more common after chemotherapy for the hematological malignancies than the solid tumors. And in infections, bacteremia only accounts for approximately 25 to 30%. In developed countries, gram-positive pathogen predominates. Significant changes in epidemiology of infections occurs during the past decades, and gram-positive pathogens have become more predominant, especially in the developed countries, because of common central line placement and prophylactic antibiotics, which covers the gram-negative bacteria and usually doesn't cover the gram-positive bacteria. On other hand, in developed countries, still gram-negative bacteria are common. Invasive fungal infections, particularly invasive aspergillosis, have become most important in neutropenic patients and are associated with fatality rates of 40 to 60%. Multiple studies done. I took a retrospective study, which is done recently in Iran from 2015 to 2014 over the 4 years, and almost 2,400 blood cultures were tested during the 4 years, and 1,414 cultures was positive cultures were included. Among them, 63.3% was gram-negative bacteria, and only 36.7% gram-positive bacteria. E. coli was on the top and followed by Pseudomonas and Klebsiella. The most alarming and the most scary thing was, out of this 63.3, 39.3% means more than 50% were carbapenem resistant bacteria. And currently we have few effective choices against MDR gram-negative bloodstream infections, especially in high-risk cancer patients, which necessitates newer treatment options. So first of all, febrile neutropenia is very important in treating infections. So the febrile neutropenia can be defined as if the patient is having fever of 101 or the temperature of more than 100.4 sustained over 1 hour with ANC of less than 500 cells per microliter or ANC expected to decrease less than 500 over the next 48 hours. Then this patient will be on the risk of catching infections. So first, in febrile neutropenic patient, to treat empirically and properly, you have to assess the risk by the risk assessment score. So Multinational Association for Supportive Care in Cancer Risk Index uses weighted scores based on disease burden, clinical instability, age, and comorbid conditions. And this risk assessment is very important to stratify the patient in different categories and to treat properly. The maximum theoretical score is 26, and it is proven through multiple studies that low-risk patients who have a score is more than 21 have mortality as low as 3%, and the high-risk patients who have scores less than 15% have mortality as high as 36%. So after risk assessment, you can stratify the patient in different categories, which includes low risk, intermediate risk, and high risk. Low risk is in which you anticipate neutropenia for less than 7 days. And these are the patients who are on chemotherapy regime for the most solid tumors. Intermediate, in which you have usually neutropenia between 7 to 10 days. And these patients are on chemotherapy regimes for the most hematological malignancies and autologous hematopoietic stem cell transplantation. In high-risk patient, anticipated neutropenia is more than 10 days, and these patients are usually on chemotherapy for the acute leukemias or allogeneic hematopoietic stem cell transplantation, or on different chemotherapy regimes. So after risk stratification, yes, we have other risk factors, with high risk factors in febrile neutropenia, which include significant comorbidities, hemodynamic instability, hepatic or renal dysfunction, grade 3 or 4 mucositis, advanced malignancies, acute leukemias, inpatient status at the time of fever onset, pneumonia or other complex infections. So after risk stratification, we will start empiric antibiotics. These empiric antibiotics has reduced the mortality in patient, but also has led to the menace of multi-drug resistant bacteria. Means it is important, but on the other hand, it also causes the resistance. So prudent use of antibiotic based on the culture reports wherever possible is of utmost importance to save the lives of infected patients and prevent further development of antibiotic resistance. So in low risk patient, first you have to consider initial or step down outpatient management if your infrastructure is in place to ensure careful monitoring and vigilant follow-up. Consider oral antibiotic if the child can tolerate orally, and in low risk FN, discontinue antibiotics at 72 hours who have negative blood cultures and who have been afebrile for at least 24 hours, irrespective of the marrow recovery status, as long as you can follow the carefully and vigilantly. In high-risk patient, we have to start broad spectrum antibiotics, which should cover gram-positive as well as gram-negative bacteria, which should have bactericidal activity, anti-pseudomonal activity, and minimal toxicity. So current guidelines recommend initial monotherapy with the anti-pseudomonal beta-lactam agents such as cefepime or meropenem or imipenem celastine or piperacillin tazobactam. It is now proven that combination therapy is not superior to empiric monotherapy, but may be associated with more side effects or adverse effects. In high-risk patients, we should add second gram-negative agent or glycopeptide for the patients who are clinically unstable, or when a resistant infection is suspected, or for the center with a high resistant pathogens. In patients who are responding to initial empirical therapy, discontinue dual coverage as soon as possible if it is not indicated after 48 to 72 hours. Means if the cultures are not suggestive of continuing VANC or AMIC, then please discontinue. So a modification of empirical therapy is very important, and it should be done after 48 to 72 hours when you have provisional cultures report, when you have provisional culture reports. And this should be done on clinical as well as bacteriological basis. In children with persistent fever who become clinically unstable, escalate initial empirical antibiotic to include coverage of resistant gram-negative, gram-positive, and anaerobic bacteria. Do not modify the initial empirical antibacterial regime just on the basis of persistent fever in the children who are very stable. And we should discontinue empirical antibiotic in the patients who have negative blood cultures after 48 to 72 hours, who have been afebrile for at least 24 hours, and who have evidence of marrow recovery. Or we should de-escalate the patient, de-escalate the antibiotics to the baseline till the recovery of bone marrow. So when we are starting antibiotics in outpatient on outpatient basis in low risk patient, we have to follow patient vigilantly. And if the patient have persistent fever after 2 days, then we have to reevaluate, and we have to consider hospital admissions if the patient is not tolerating orally, or if the patient is sick, or admission, or if the patient is not patient can't be managed on outpatient basis. In high-risk patients, we have started inpatient empirical antibacterial regime, and we have to follow for next 3 to 4 days. If fever persists after 4 days, then we have to send fungal workup and start antifungal therapy. So coming to the antimicrobial prophylaxis. The National Comprehensive Cancer Network recommends the use of prophylaxis just in the high-risk patients, not in the low-risk patients. And fluoroquine is the drug of choice for the high-risk patient. And if in low-risk patients, it can increases the risk of resistant bacteria. So meta-analysis was done in which 18 trials were included, and the number of patient was 1408, with including both solid and hematological malignancies. Prophylaxis was fluoroquinolone prophylaxis was given, and it was observed that fluoroquinolone prophylaxis significantly lowered the incidence of gram-negative bacteremia by 80% when compared with the placebo, and by 70% when compared with the Septron. So we can say the antimicrobial prophylaxis should be given in high-risk patients. So coming to the fungal infections. In fungal family, we have 3 classes: yeast, dimorphs, and molds. Dimorphs are very uncommon, so we will discuss the yeast and molds. In yeast, Candida is very common, and in molds, Aspergillus, mucormycosis, and Fusarium are common in immunocompromised host. First of all, when the patient arrive, you have started empiric antibacterial drugs. And if the patient is not improving after 4 days, and patient is having persistent fever, and patient is unstable, then you have to think about the fungal infection, and you have to do workup and start antifungal therapy. And this workup includes cultures, radiology, histopathology, and biomarkers. In cultures, blood cultures are good for Candida, but not for the molds. And tissue culture can be miss the mold infections. Sputum and bile are more sensitive for the molds, and however, false positive may occur in the presence of beta lactamase inhibitors. Chest X-ray are very insensitive to diagnose early invasive aspergillosis, but HRCT is very sensitive for the early diagnosis. On the other hand, histopathology is good, but it can miss the diagnosis, but it differentiate the mucor from the other modes. In biomarkers, we have two things, galactominin and beta-D-glucan. Galactominin is the fungal marker which is present in aspergillus only, and it can be done in serum or BAL. Galactominin is very specific, but it's not sensitive, so it can miss the diagnosis. Galactominin has prognostic value, and important false positive are the beta lactamase inhibitors. On other hand, beta-D-glucan is the fungal marker which is present in all fungi but not in the mucor, and it is present in 50% of the cryptococcus. It is very sensitive, but it's not specific, and it varies according to the organism. And in advanced testing, we have a fungal identification on cultures through the DNA sequence analysis and multi-TOF testing, which is just present at NIH. So, interpretation of these diagnostics are very important, and you can use empiric antifungal very easily if you interpret it in a good way or in. So, let's discuss it.
Sorry, Dr. Samina, to interrupt you in the middle. Uh, we will be taking questions at the end, and some unsaid things can be answered then. Um we will be proceeding towards the last talk of today's session, and this will be done by Dr. Shamvil, and it's a pleasure and honor to introduce Dr. Shamvil Ashraf. He's a consultant and pediatric oncology and executive director medical services at Indus Hospital and Health Network. He did his MBBS from Dow Medical College, specialized in pediatric oncology from Ireland and UK. Dr. Shamvil has worked at Shaukat Khanum Cancer Hospital, Lahore, Ziauddin Cancer Hospital, Karachi, Children Cancer Hospital, Karachi, and currently at the Indus Hospital since 2014. His vision and mission are to improve and enhance childhood cancer awareness, treatment, and survival, and to establish replicable medical services framework across Indus Hospital Health Network. He is founder member of Children Cancer Foundation Pakistan, founder and chief executive Children Cancer Hospital from 2000 to 2014, and past president of PSPO, member of society, member of PSYOP, and member and past board of director POEM and life member of PPA. So over to you, Dr. Shamvil.
Thank you. Assalamu alaikum. Is my screen shared with you?
No, sir, your screen is not visible.
Okay. Share. Share the screen. Please share the exam.
क्या हुआ? Sorry for a little delay due to some technical issue. Dr. Shamvil, you can start your presentation now.
Yeah, okay. Sorry for the technological interruption. Bismillahirrahmanirrahim. Thank you, Korat, for the nice introduction. What I'm going to go over the next 15 minutes is when to suspect malignancy in children, and it is particularly relevant to the pediatricians and general practitioner. We see what are the common cancer in children. Most common cancer in children are leukemias and brain tumor in the West, and but in our data, leukemia and lymphoma are the most common tumor. Then we have bone tumor, soft tissue sarcoma, brain tumors, retinoblastoma, neuroblastoma, Wilms tumor, germ cell tumor, and the other tumors. Before going into the main topic of when to suspect malignancy in a child, it is very important to understand that pediatricians have a very important role in pediatric oncology because they are the first contact for the patient in most of the time. And they are very important for early diagnosis. That is why we have chosen this topic, when to suspect and early diagnose. Then proper workup for staging and risk grouping can be done by the pediatrician. Initial stabilization, proper referral is very important, and similarly shared care with the other pediatric oncology unit. And once they are a little bit trained, they can give easy treatment at their centers. So pediatricians play a very vital role in the development of pediatric oncology and shared care. But before going into that, we must understand that we have to understand when to suspect malignancy in a child. And this is one scenario of child with petechiae onychomycosis. And this is a very not a very uncommon presentation when a child presents with fever, pallor, and has petechiae onychomycosis. So in this case, I think we have to think about the low platelet count and petechiae and ecchymosis due to the low platelet count. And then child may present with pallor, bruises, and bone pain. In such cases, the one has to suspect leukemia, and this is one of the common presentation for leukemia. Not all children presenting with the pallor and bruises are leukemia, but you have to keep in mind that leukemia can present with this. Similarly, bone pain are not uncommon in JRA or juvenile rheumatoid arthritis, but if the child has pallor and persistent bone pain, one should also suspect leukemias in these children, and should look for CBC and to look for the blast cells, or the peripheral isthmus need to be looked at. So this is a common scenario in our general practice. And as a pediatrician, you do see children with bruises, petechiae, pallor, bone pain, and in such cases, one has to have a high index of suspicion for leukemia. Similarly, children present with lymphadenopathy and lymphadenopathy are not uncommon in children, but not all lymphadenopathy are cancer or can be cancer. This is a very common presentation in children. So, but any lymph node or lymphadenopathy which is more than 2 centimeter or 3 centimeter, which is progressively increasing, which is not resolving with the standard treatment, or which is persistently increasing in size, should be thought about lymphoma or cancer of lymph gland or metastatic lymphadenopathy. Sometimes they are associated with fever, cough, difficulty in breathing or sweating, and such symptoms are very often happen in tuberculosis as well, and it is not very uncommon to be treated as a tuberculosis. And we do see a lot of children presenting late with a large lymphadenopathy in the neck, being treated for TB for more than 3 to 6 months. So this is not a nice approach for the child with a lymphadenopathy of larger size or progressively increasing. One should suspect that it could be a Hodgkin disease, or it could be a non-Hodgkin lymphoma, or it could be any other malignancy in this. And in such cases, a lymph node biopsy should be done, and child should be investigated for the lymphoma. One of the two myths which I want to clarify at this stage is, one is that you should not treat tuberculosis in a large lymphadenopathy without having definitive evidence of tuberculosis, or you have ruled out malignancy. The second important myth is that doing an FNAC in such cases. You can often miss lymphoma with FNAC, which is fine needle aspiration cytology, can often miss because it does not take true tissue representation in many cases. So if you are suspecting lymphoma, you must do a lymph node biopsy, and that will tell you whether it is a tuberculosis or lymphoma. And sometimes people are good at why to subject child with a lymph node biopsy, why not give a trial of tuberculosis. I think this is not I would never recommend this. I think it is very important that even if it is a tuberculosis, you should do a biopsy and confirm your diagnosis. Otherwise, you will unnecessarily treat tuberculosis, and this is will delay the diagnosis of lymphoma. Children presenting with abdominal masses, abdominal distension, unusual lump in the abdomen should be suspected for malignancy in cases where it is persistent, it is increasing, child is unwell, or child is child can be well as well in many tumors. But if it is often you can feel a mass which is large enough to be palpable, then you should do a screening ultrasound to know whether it is arising from the gut or the kidney or from liver or so on and so forth, or abdominal lymphadenopathy they can present. So lymphomas, Wells tumor, neuroblastoma, liver tumor, sarcomas, they can all present with an abdominal mass. How to approach it is a different topic, so I won't go into detail. But any palpable mass in the abdomen of malignancy should be suspected, and unless it is a very isolated splenomegaly or something like that. Otherwise, most of the tumor from the abdomen, they present with a mass, abdominal distension and discomfort. The child may be well, the child may be sick. An ultrasound is very important to find where the mass is arising, and then further taken from there. One of the common presentation for one of the common tumor in the eye in younger children is retinoblastoma, and these children present with leukocoria or white eye reflex. Cat eye reflex, what we call is a cat eye reflex, and if you see the picture, you can see that there is a whitish spot which is called leukocoria, and they can also present with the squint. Sometimes the children present with the squint to the eye people or to the pediatrician, and they say the child is very small, so let him grow and we will see him after 6 months. This is not the right approach. All the squint, all the white reflex should be investigated for the retinoblastoma. A detailed examination of the eye is very important to look into the fundus and to look into the rule out the tumor which arises from the retina. And in developing countries, most of the children present late because we do not examine properly the eyes, even if the eye shows some squint or from the leukocoria or the cat eye reflex. So retinoblastoma is a treatable, is a very treatable disease. You can save the eye, you can save the life in more than 95, 98% cases, or even 100% cases if you diagnose it early. So it is important that all pediatricians should know, understand that the white eye reflex is a must be taken seriously. Similarly, all squint must be taken seriously, and the retinoblastoma should be ruled out. Children often present with the bone pain and unwell, so a little bit of bone pain at the limb, maybe on different side of the limb. In such cases, we usually give them a small analgesic or something and say it is nothing to worry about. But if it persists, then you need to worry about it, because like sometimes they present with the bone tumor in this way, or the soft tissue sarcoma, they can also present in this way. So body ache and bone joint pain, swelling should be taken seriously. And if it is persistent and more than like 10 days or 2 weeks and it is not going with the normal analgesic, a plain x-ray should be done for the bone tumor. This is the first screening investigation, and it will show you the destruction or the changes in the bone. So if there is a tenderness, if there is a pain, you must take it serious, and you must investigate by a plain x-ray to rule out bone tumor. Headache and vomiting are very common presentation in children. Not all headaches are due to space occupying lesion or the brain tumor, but if the headache is accompanied with the nausea and vomiting, or with the vertigo or imbalance, then you must take it. You must take must take it serious, and you must think about brain tumor or a space occupying lesion. So early morning vomiting, similarly poor school performance associated with headache, eye changes or visual problem associated with vomiting or headache should be taken, should be brain tumor should be considered. In many cases, the diagnosis is delayed because we don't think about brain tumor. We think that this is because of the child is psychologically unstable or so and so forth. So in this era, a CT and MRI is not anymore a very fancy or very expensive investigation. If the child is symptomatic and has headache, vomiting, or imbalance, difficulty in walking, or visual issues, then a CT scan and MRI an MRI should be done to rule out brain tumor. So this is similarly changes in the mood are very for the frontal lobe tumor is one of the presentation. So until and unless you have ruled out a space occupying lesion or a brain tumor, one should not label the child as a psychological problem or the psychiatric problem. Children can present with proptosis, and proptosis is because of the deposits of the most of the time is the deposit of the tumor around the orbit, and it can be presentation of acute myeloid leukemia or leukemias. More commonly, acute myeloid leukemias can present with the Langer's histiocytosis, and in such cases, the child should be investigated for retroorbital tumor as well. Some can push the eyeball forward. So in these cases, neuroblastoma can present or fibromas or sometimes soft tissue sarcomas of fibrocytic origin can have retroorbital location, and they can push the orbit. Similarly, deposits of chloroma in AML can lead to proptosis, and Langerhans cytocytosis is also. So in such cases, a CBC should be done to look it for the blast, and similarly, imaging should be done to look into the cause of the proptosis. Raccoon eyes are sometimes small children present within the 5 year of age present with the raccoon eye, and these are the presentation of neuroblastoma, and one should suspect neuroblastoma and look for the primary which can be in the abdomen or which can be in the thorax. So this is another presentation of cancer in a child. So neuroblastoma can present with raccoon eyes. So these are the common presentation, and these are the common scenario you see in your daily practice. But if you have in your differential diagnosis, then you will go for investigation, and then you can reach to early diagnosis and early referral. So the screening tests are very simple. If the child is presenting with the fatigue and pallor and unwell and is not responding to your usual treatment, and if the symptoms are persisting for more than 2 weeks and has got petechiae or bruises, then you should do a CBC and peripheral smear and look for the blast. And most of the time you will find the blast in these cases, and then you refer them for the further investigation. Similarly, children presenting with the cough, breathlessness, and the superior mediastinal syndrome and different other presentation of tightness in the chest and other thing, then a chest x-ray will tell you the diagnosis or suspect the diagnosis on a chest x-ray, which is further confirmed on CT scan and a biopsy. Abdominal masses can easily be picked by a ultrasound, and for the bone pain and tenderness, you can do a plain X-ray of abdomen. And as I said, if the headache is persistent, is with vomiting and with difficulty in walking or poor performance in the school or psychological problems, which looks like a psychological problem, emotional problem, then you should do a CT and MRI brain to rule out this brain tumor. And then further, according to the finding, you take it forward. Child with back pain and limb weakness is another presentation which I just added because sometimes children present with a limb weakness, and if you look at you may find that these symptoms are because of the spinal masses, and non-Hodgkin lymphoma, Ewing sarcoma, neuroblastoma can present with these signs and symptoms. So if your examination rule out the common causes of the limping, the most flaccid paralysis or those sort of things like Guillain-Barré or transverse myelitis or those sort of things are ruled out, then you must think about the spinal tumors. And spinal tumors are very oncological emergencies. They have to be diagnosed early and treated early to prevent the paraplegia. This is one of the poster done by the SIOP, Society of International Pediatric Oncology, which tells you all the common signs and symptoms, and I have gone through all these. So just a recap of this. So in conclusion, pediatricians have a very critical role in improving childhood cancer survival by early suspicion and early diagnosis so that treatment can be done properly, and the chances of survival becomes very high if they are diagnosed early, and they can only be diagnosed only if you suspect them early. So this is very important. Proper workup in consultation with pediatric oncologists ensures accurate diagnosis and risk grouping. Shared care and establishing a small unit is the way forward to improve cancer care in children. And initial counseling and proper referral is also important for patient point of view. Thank you very much for your attention.
Thank you so much, Dr. Shamvil, for your talk. It's always a pleasure to listen to you whenever you give a talk on any topic. And I thank all the esteemed speakers who took out their time for their wonderful talks. And our apologies for any technical glitches and interruptions due to time restrictions we had. We are open to questions. I would like to ask Dr. Rafi, who's chairing the session, if he has any question, and then I have a few questions.
So, thank you everyone for joining us. My question is here from it is sent by Wajid Hussain. It's from Dr. Sadaf. Do iron overload affect the outcomes of BMT in thalassaemic patients? And do we need iron chelation even after BMT? Yes, Dr. Sadaf. I think we can't listen you, hear you, Dr. Sadaf. I think your internet is having trouble.
Can you hear me?
Yes, no, I can hear you.
Okay, fantastic. That's a very important question that was asked regarding outcome of transplant and iron overload. So iron overload is really a very important prognostic factors in terms of the success of the transplant. Historically, what was used was the Pissarro classification. Pissarro classification was one of the prognostic sort of criterias that predicted कि किसका transplant जो है वो successful होगा, and one of the factors in it was the iron overload. So before we take a kid to transplant, we really make sure that the history of chelation was good, because if we know that chelation was bad, then we know that the transplant will not be successful. The other thing is, prior to the transplant, 6 weeks before the transplant, we do preconditioning where we do aggressive chelation of the child to improve their outcome of the transplant. Thank you.
Thank you. Yes, Dr. Kurat, do you have any question?
I have a question for Dr. Sadaf. We see a lot of patients being treated for non-transfusion dependent thalassemia majors, and what we see mostly is that their chelation and their ferritin levels are not being monitored. They are kept on hydroxyurea, but without any adequate monitoring, and we ultimately see them with huge spleens and not very well managed. So, do we follow the same guidelines as our transfusion dependent thalassemias for those children as well, considering the ferritin monitoring and T2 star and radiation therapy?
Yeah, thank you for that question, Kurat. In my talk also, I mentioned that iron overload in children with non-transfusion dependent thalassemia is different than iron overload in transfusion dependent. What happens is these children have a lot of iron deposition in their liver. So the mechanism is also they have a lot of iron that is absorbed from their gut. The guidelines recommend actually regular chelation starting around age 8, 9, or 10. That is the general, whereas in transfusion dependent, you start it much earlier, which is around age 2. So I think it is really, really important to serially monitor ferritin in these children, because the issue is not so much cardiac in these children, it is more liver related. And we don't have very good scans, or we don't have any scans in Pakistan to monitor iron overload of the liver in patients with non-transfusion dependent thalassemia.
Thank you, Dr. Sadaf. One question to Dr. Asim is that considering the incidence of thalassemia minor in our population, do you recommend HPLC to be done for any kid with microcytic hyperchromic anemia? Because again, what we see is that they are given iron without any HPLC testing or anything of that sort, and many of the thal minors are missed in that case. And also, when they present with a hemoglobin of 5 or 6, is that the right time to get a HPLC done, or do we give an iron challenge and then we do it after 3 to 4 months?
Thank you for the question. The issue is the HPLCs are not very accurate, or will give you false negatives at a very low hemoglobin. So generally speaking, it's advised that you, first of all, because there can be a concurrent iron deficiency given our area and in our country. So it's always better to give iron first. If the iron deficiency is also part of the problem, it comes up, then you will have better HPLC results. Otherwise, on very low hemoglobins, your HPLC will give you a false negatives rate. So yes, you give iron, you can never go wrong with just giving iron, given our situation in Pakistan or in any developing country. And then if it's not getting better, because remember, HPLC is another added cost to your full blood count or your complete blood count. So give your iron, and then it's still not getting better, then you have to get your HPLC.
Yes.
Thank you, Dr. Asim. Do we have Dr. Samina? Are you out there online?
Till she is online, I have a question from Dr. Shamvil. Dr. Shamvil, you told in your talk that pediatricians have a critical role to improve childhood cancer survival, and there should be proper referral and proper counseling. So can you please clarify that how they can improve childhood cancer survival in our country? What is their role?
I think the first contact of the patient is usually with the pediatrician and general practitioner. One of the major problem in our country is the late diagnosis, whether it is retinoblastoma, whether it is solid tumor, whether it is leukemia, and whatever. So I think the diagnosis, the problem starts from the symptoms to coming to the doctor, and then from doctor to the coming to the specialist. So this is one where I think the delay is mostly at the level of the general practitioner and pediatrician. They don't suspect malignancy in the child, and they keep treating them for the common problem, and then when it becomes very advanced, then they suspect it and then they are referred. So by that time, the curability of the cancer decreases itself, because if you can diagnose something early, your chances of survival is high. So number one. Number two, so this is very important that an early diagnosis is because of the first contact of the patient is pediatrician and general practitioner. So if they can suspect early, we can get an early diagnosis. Secondly, many of the times the children are admitted in the general pediatric ward for the even if they are diagnosed with the some abnormality on the blood film or from the ultrasound, they are investigated in the peripheral hospitals and in the general ward. So if they have some training of doing proper investigation and confirming the diagnosis, this can also give an a better chance of survival for children. So if, for example, a lot of time we see the patient who has been seen at the, for example, in one of the peripheral hospital, teaching hospital, and has a bone marrow is done, and that bone marrow is done with a morphology only, and the morphology says leukemia or acute myeloblastic or acute lymphoblastic leukemia, and he gets a dose of 2 doses of steroid, and then he is referred to us. So now everything is now masked. You don't when they come to you, the bone marrow is a remission. You don't know whether it is leukemia, it is AML or ALL. You don't know whether it is high risk or a low risk cytogenetically. So these are the things which I think is a basic training in the pediatric hematology oncology for pediatrician, because we are far away from having a pediatric oncologist in all teaching hospitals. We have to train those pediatricians to get a proper diagnosis, to get an early diagnosis, and that is how we can improve the survival of those who are coming to us.
Thank you. Yes, Dr. Kurat. You are muted.
So I have a question for Dr. Samina, that we see febrile neutropenia kids every day, and most of the time we don't find a focus and they are constantly running fever. So do we do a CT scan on day 5 of fever irrespective of the focus or not? Because that adds on to the radiation exposure as well as the cost. And many a times we don't find any evidence of fungal infection on those CTs. But still, do we really need to do those CTs, or do we rely on sending a beta D glucan and galactomannan? What would you say? Dr. Samina, are you there? We can't hear you.
I think
there's some internet issue. We are already running out of time. Dr. Rafi, I would like you to give concluding remarks. And
regarding your question, I think CT scan in every child on day 5 is not recommended, and you will have to go empirically. But if there is high suspicion of fungal, of course you can get a CT scan done. And similarly, beta 2 diglucan and galactomannan routinely nowadays are not recommended to investigate fungal infections, and the current guidelines do not recommend them. So yes, CT scan should be done in those cases where you have high chances of suspicion. And if there is any other question,
I have one last question from Dr. Sadaf, asked by Dr. Zahida Baloch, and she says she's asking exact survival age of thalassaemic patient, and in which age there is a possibility to manage thalassemia patient. If Dr. Sadaf can answer.
Okay, so I think I'll be very quick because I know you all are running out of time, but basically there's no exact age that we can sort of say that they live up to this age. It depends on how well they're managed. If they're given transfusions on time, and if chelation is done, then they can, we have patients living into their late 40s, living normal lives. And if you have diagnosed a child with transfusion-dependent thalassemia major, the management begins right at that point with transfusions, and then chelation to start at age 2. That is the most basic level of management for a patient with thalassemia major, beta thalassemia major.
So that's all. We
Thank
don't
you.
have any other questions.
Okay. Thank you, everyone. Thank you to our participants and to our speakers for making wonderful talks. And I would like to know the participants that there is International Childhood Cancer Day on 15th February every year. And the flyer, which was displayed by Dr. Shamvil, we can provide to the pediatricians and pediatric hospitals, pediatric departments. They can display in their outpatient departments for the awareness of the parents, so that they can come to diagnosis early. Similarly, we will be happy if they are interested to do any workshops in their departments. They can contact us, and we'll be happy to conduct these workshops in Karachi and even in the interior Sindh if someone wants there. And I am thankful to all our speakers, as well as Dr. Kurat as a moderator for her good moderation. And we are sorry for the few glitches which happened in the streaming due to technical problems. Thank you, everyone.
Thank you so much for the invitation.
Thank you.
Thank you.
Thank you.
Thank you. Allah Hafiz.